Hemoglobin formation begins in the first stage, which is the proerythroblast stage, and it continues even up to the reticulocyte stage. So reticulocytes will continue to produce hemoglobin until they become mature erythrocytes. So a simplified version of hemoglobin synthesis is that 2 molecules of succinyl-CoA and 2 molecules of glycine form a pyrrole. 4 of these pyrroles arrange themselves to form a protoporphyrin 9 ring, and this protoporphyrin 9 combines with iron to form heme. The heme combines with a polypeptide chain to form a hemoglobin chain, which can either be an alpha or a beta chain, and when 2 alpha and 2 beta chains combine, they form hemoglobin A. The total amount of iron in the body is about 4 to 5 grams, and in descending order, its distribution is 65% occurs in the form of hemoglobin, and 15 to 30% is found in the reticuloendothelial system, as well as in the liver in the form of ferritin, and 4% is found in myoglobin, 1% is found in other heme compounds, and 0.1% is found combined with transferrin in the plasma. So besides hemoglobin, iron is also present in many other compounds like myoglobins, cytochromes, cytochrome oxidase, peroxidase, and catalase. So the transport form of iron in the plasma is known as transferrin. Iron combines with a plasma protein called apotransferrin, and this apotransferrin is then basically becomes transferrin. And the storage form of iron is mainly in the form of ferritin. The iron combines with apoferritin, mainly in the liver, and it is stored in the form of ferritin. So another storage form of iron can also accumulate, and this form is called hemosiderin. But hemosiderin accumulates only when there is excess iron present in the body, so it's stored as an insoluble form called hemosiderin. So once the transferrin reaches the erythroblasts in the bone marrow, it binds to receptors on their cell membrane and is taken up by endocytosis. So people who lack transferrin, they develop hyperchromic anemia. Hyperchromic means low hemoglobin. So in this anemia, there is low hemoglobin than normal. Because in the deficiency of transferrin, enough iron cannot be transported to the erythroblasts, and that's why the people develop anemia. The daily loss of iron in males is about 0.6 milligrams a day, and it occurs into feces. And in women, the loss is almost double, and this is about 1.3 milligrams a day, and this loss occurs both in feces as well as menstrual blood. So in the body, iron levels are not controlled by controlling the excretion of iron, but instead the iron levels are controlled by regulating its absorption. This means that when iron stores inside the body become very high, then the rate of iron absorption is decreased. But if the iron stores in the body become low, then the rate of absorption is increased. So here we are not excreting iron, instead we are controlling the rate of its absorption. The lifespan of an RBC is 120 days, and after that the RBCs become fragile, and many of them undergo self-destruction when they pass through the red pulp of the spleen. And so because the spleen is responsible for the destruction of RBCs, its removal would obviously increase the number of old and abnormal RBCs in the blood. Besides self-destruction, RBCs can also be taken up by macrophages of the reticuloendothelial system, and they can undergo destruction. So either way, destruction of RBCs releases hemoglobin, and this hemoglobin is taken up by the macrophages, especially in the liver, spleen, and bone marrow. The hemoglobin is broken down into heme and globin parts. The globin part enters protein metabolism, and the heme part is further broken down, and eventually the heme part becomes bilirubin, and bilirubin is transported to the liver where it is excreted into bile, and the iron that is released is passed back to transferrin in the blood, and transferrin carries this iron to the bone marrow for the production of more RBCs. Anemia can be defined as a decrease in the RBC count or the hemoglobin concentration below a reference level, or in simple words, you can basically call it a lack of RBCs or a lack of hemoglobin, but this is not a proper definition. It can be classified into hemolytic, blood loss, aplastic, and megaloblastic. Hemolytic anemia occurs whenever RBCs become so fragile that they rupture easily when they pass through blood capillaries. And so any disease in which the RBCs rupture easily causes hemolytic anemia, such as hereditary spherocytosis, sickle cell anemia, and erythroblastosis fetalis. In hereditary spherocytosis, the RBCs are spherical in shape, and rather than being biconcave discs, so they can't withstand compression forces, and they easily rupture. In sickle cell anemia, it's caused by a mutation in the beta globin chain. Hemoglobin S is produced. At low oxygen concentrations in the blood, the hemoglobin S precipitates inside the RBCs, and this causes the RBCs to become sickle shaped and causes the cell membrane to become fragile, which easily ruptures the RBC. So a sickle cell disease crisis occurs when there's low oxygen concentration in the tissues, which increases the sickling of RBCs. Sickling makes the RBCs more fragile, so they rupture easily. When the RBCs rupture, this further decreases the oxygen concentration inside the tissues, and this low oxygen tension promotes even more sickling. So this process continues and continues like a positive feedback cycle, and eventually it can lead to death. And erythroblastosis fetalis occurs when an Rh-negative mother is carrying an Rh-positive child. And so the mother's body makes anti-Rh antibodies, which diffuse across the placenta. And these RBCs are going to cause destruction of the fetus's RBCs. Blood loss anemia is caused by chronic blood loss, for example, after a hemorrhage or after a hookworm infection. So when excess blood loss occurs, iron cannot be absorbed from the intestines rapidly enough to form hemoglobin. So the RBCs in this type of anemia, they are smaller than normal, and this blood loss anemia can also be called microcytic hyperchromic anemia. Microcytic means small RBCs, and hyperchromic means less hemoglobin. Aplastic anemia occurs whenever there is a dysfunction or a destruction of the bone marrow, and this can be caused by high dose radiation, for example, in chemotherapy, and also toxic chemicals like insecticides, benzene, and gasoline, and also autoimmune diseases like lupus erythematosus, and it can also be idiopathic without any underlying disease. And these patients require blood transfusions or bone marrow transplantations. Megaloblastic anemia can also be called maturation failure anemia, as we talked about previously. And this type of anemia is caused by the deficiency of folic acid, vitamin B12, or intrinsic factor. Folic acid and B12 are required for DNA synthesis inside the RBCs, and intrinsic factor is required for the absorption of B12. So any factor which causes a deficiency of either folic acid, B12, or intrinsic factor results in megaloblastic anemia, because DNA cannot be synthesized and there's failure of nuclear maturation, there's slow reproduction, the RBCs continue to increase in size, and their membranes become fragile, and they are prone to being ruptured easily. So the ultimate effect of anemia is that it increases the cardiac output and workload on the heart. This is because, first of all, a decrease in the RBC count would decrease the blood viscosity, and this decreases the resistance to blood flow in the blood vessels. So there's increased blood flow towards the heart and an increase in the cardiac output. And secondly, when there's anemia, there's hypoxia in the tissues, and this hypoxia causes vasodilation to happen in the tissues. This vasodilation has the same effect. It further increases the venous return to the heart and further increases the cardiac output. So the workload on the heart is increased. Polycythemia basically means an excess of RBCs, and it's of two types, secondary and primary. Primary is also called polycythemia vera or erythemia. Okay, so polycythemia vera is always pathological, and it's caused by a mutation in the hematopoietic stem cells in the bone marrow, which are responsible for producing all types of blood cells. So a tumor of these hematopoietic stem cells would result in the excess production of RBCs, and as well as other blood cells like white blood cells and platelets. On the contrary, secondary polycythemia is not pathological, and it's caused by any factor which causes hypoxia in the tissues, like high altitude or cardiac failure or pulmonary diseases. These are all secondary reasons. And an example of secondary polycythemia is physiological polycythemia, which occurs in natives that live at high altitudes between 14,000 to 17,000 feet. So, at high altitude, there is low oxygen, so a low concentration of oxygen in the tissues would promote the production of erythropoietin and eventually RBC production. Because the RBC count in polycythemia is increased, blood viscosity is increased, so the peripheral resistance to blood flow is increased, and this decreases the cardiac output. But at the same time, the increase in the RBC count also increases the blood volume, and this increase in blood volume promotes venous return and increases the cardiac output. So these two factors cancel out each other, and the cardiac output stays normal. And the arterial pressure can either be normal or elevated. It depends upon the blood pressure regulating mechanisms in that person. A clinical sign of polycythemia is cyanosis, which is the bluish coloration of the skin. So this happens because blood flow in the capillaries of the skin, it becomes very slow, and by the time this blood reaches the subpapillary venous plexus, a large amount of hemoglobin becomes deoxygenated,